Warm welcome to the next session towards state of the science in person-centered care, which is a track for the rest of the afternoon if you make that choice. And the person-centered care knowledge is extensive and proliferating, and marked by a combination of empirically based grounded knowledge and major theoretical frameworks. So for the next 3 sessions this afternoon, we will take steps towards this state of the science. And we find it specially motivated by having several key scholars in the field present at our conference, both here and here, of course. And so we have the special opportunities for taking steps towards summarising to what we know and what we do not know. And the goal is to provide an overview of the current knowledge of person-centered care in a generic sense, and that critically could picturise where the theoretical empirically informed advancement has reached so far. And the overall purpose of the initiative is to provide a benchmark to further the scientific progress and possibly invite to a State of Science conference in the future. So now we will start, before we go into an overview and presentation of 4 major frameworks, we'll start with a framing of the discussion about the development of person-centered care in relation to the broader societal trends and movements, by Professor Axel Wolf, Professor at the University of Gothenburg and Director of the Center for Person-Centered Care. Welcome.
Thanks. Perfect. So, and I will try to put mainly person-centered care in context with precision health, and I will tell you why later on. And this timeline, you don't need to look at all of it, but I mean, like we heard yesterday, we have had quite a long time doing research in person-centered care and other topics in that sense, and I mean, it's happening. We are in the tipping point, I believe. But I will focus on precision medicine. And 2015, Obama had a huge push for precision medicine. But also before that, in 1990, the Human Genome Project started. So, I mean, that's also 30 years ago. So if you think that it's going slow, I mean, maybe things take time in that sense. But I will focus on precision medicine, and then also a little bit on the societal level. And why now? I think that why now is because the future is data and analytics. And right now we have a perfect storm where we have the capacity, we have the storage, we have the cloud storage, we have the regulations that's starting to go inside, and we have the analytic power with AI. So we can do very, very cool things. And also importantly, we can do good things for the patients, I believe. The question here, of course, is if data is the future, what kind of data? And I think that we all in this room, and that's my point here, we need to take space and say that it cannot be only one sort of data that goes into these kinds of algorithms. So we need to understand that we need to have a comprehensive set of data if we want to have a more information-driven approach. So historically, I think that we have divided more than combined personalized medicine, which is very much into the genomics and to understand the medicine through the lens of the gene of the person, and then also to understand how you can tailor care to it. And we separated a little bit from person-centered care. And also if you look at some articles, this is one article that I tried it, and if you have precision medicine or personalized medicine, I come back to it, why I call it precision medicine, personalized medicine, and PCC to right here, you see that they have tried to divide it a little bit because they thought it was a little bit, there is a difference between those 2 models. And they make quite an interesting figure with the basis is the genetically unique individual, the body, and the basis of PCC is a complex individual person. And then on the top level, the purpose of it is to optimize medical outcomes, and the purpose of PCC is empowerment. I don't really agree on that. And that's my point. I think that, and they come to, in the end of the paper, I think they're trying to summarize it a little bit, but I think it's very, very dangerous if we separate those 2. I mean, we are a body and we are a mind in that sense, and we treat the patient, we need to have both sides. And I mean, if we take this poem from Thomas Tranströmer that I got from Bengt, two truths approach each other. One comes from within, one comes from outside, and where they meet, one has the chance to see oneself. And that's a translation from the Swedish version. But so I think that what we have done, and what I think can be a little bit problematic, I would say, is that I think that we have separated the subject from the object, because maybe we are more on the side of the life world when we talk about person-centered care, and we think that the medical side is on the biological side. But I think that we need to rethink and to integrate those. Of course, because if you meet a patient, they come to us both with the signs that we can look at objectively, and then their own experience, the symptoms of disease, like breathlessness, tiredness, and we need to combine those two in order to both understand why do the patients seek care, the impact of the patient because of their symptoms on everyday life, the motivation and goals, and of course, then you could also agree on something in the health and care plan. But we need to combine the different expertise, and I think that we will hear more about it later on. So that's why I think that you also have seen a shift nowadays, that we don't longer talk about personalized medicine, and we have a shift into precision medicine. And that occurred during the 2015 when Obama then talked about precision medicine. And that was because it was a little bit too narrow with personalized medicine, even for precision medicine. They were a little bit narrow, which is kind of funny when you talk about precision, but that's another way. So nowadays we call it personalized medicine, but it's still about understanding the phenotypes of a patient and understanding it through blood samples. But now they also include sensors and the understanding of the external factors. So phenotype is, of course, also external impact. So there they have broadened up the system. However, today we have already scaled that, and because we don't have a good definition on precision medicine or precision health, I think that we are going more and more into the terminology of precision health, which is both predicting, both preventing, both diagnosing and treating. And in that sense, I believe that we have a perfect mix here to understand the combination of precision health with person-centered care. But there's very, very little written about that combination. I think that we really, really need to step up our game here. This is a very, very nice publication in circulation about the impact of neighborhoods. And this is from the States, of course, in that sense. So many of the things that they write about are mainly from the US system. But I think it's nice to see that it's down there in the individual, but then you have the interpersonal environment, both the relationship between the clinician and patient, but also social networks, household, informal carers, for example, is also important. But then the neighborhood, the environment, the sustainability. If you have problems with miljöförstöring, now I swinglish a little bit, but that's okay. Miljöförstöring på Brenda, what's miljöförstöring in English? Climate change. So we need to take that also in account, and we can do it good. Because we have the data and we have the power of the analytics, and we have the citizens that collect data in that sense. So we need to see it, and it's glad to hear from Brenda that we're starting to also see it as a whole system approach in that sense. So healthcare is not isolated. And here we, of course, also have other social movements where the citizens, with, for example, citizen science, so on and so forth, where we can collect data and create knowledge together. And that is one social movement from, this was a publication from Nesta about health as a social movement, where they show that, of course, that we need to co-create knowledge, but we need also to understand what kind of questions do we ask. What are the urgent problems that citizens have? Maybe not only inside the hospital or primary care setting, but also other settings in order to understand. And that brings me down to that if we really want to transform our system, we need to co-lead it together. And that, of course, is the type of movement that we all need to create, both inside the hospital or a primary care setting, or which kind of healthcare system we talk about, but also other systems around. So I think that's my last slide. I think that we need to get all the pieces together, and we are on a good journey right now. But from my perspective, I really urge you not to forget precision health and precision medicine, because we need also to be part of the discussion how we combine it with person-centered care, both regarding the research but also in practice. And one aspect would, of course, be prompts and prems, which we will hear more about a little bit later on. Thank you.
Thank you so much. And now we will turn over to brief presentations of the frameworks. And first, Dr. Inger Ekman, professor at the University of Gothenburg and the founder and first center director of the GCPCC. And you will talk about person-centered care with a foundation in ethics. Warm welcome.
Thank you, very briefly. And Axel, I didn't see your slides because look at this. Same. But I agree, and that is a point of departure actually in our framework and in our applied ethics, that the human being, the person, is also an object. But first of all, and as you can see, Axel, I framed the subject more, because we are used to the culture in healthcare is medical. It's an object, it's diagnosis, it's fragmentized, as I think we all agree. And I know that Brandon emphasized very much culture change, and we are totally in agreement of that. But our applied ethics in the person-centered care, it is Paul Ricoeur's ethics that the Swedish philosopher Bengt Christensen Uggla really guided us from the start to see how can we apply this. And here it's a citation from Paul Ricoeur. Me and my body cannot be separated, but still are not the same. So the life world, of course, is something that is dominant in person-centered care, but also always the object, the body, the organs, the genes. So the ethical aim, as some of you maybe heard in the opening talk I had, it is also from Ricoeur. It's very short, but it contains a lot. Aiming at the good life with and for others in just institution. So within this, it's also the autonomy of self, or myself, my self-esteem. I aim for the good life, but together with others, always together, always directing towards other, being together in partnership. But it have to be in just institution. We aim for justice. So wherever I go, each and every one, the anonymous other out there, all of you, you should feel, you should know this is a just institution. Everybody works for it here. And assumptions that are quite clear in our applied ethics in person-centered care, that we are vulnerable. We are vulnerable towards others' suffering. We recognize it, and in some of our professions here, we are physicians, nurses, occupational therapists, physiotherapists, and so, etc. We are very sensitive to it, and we know we need to take acts to relieve. So we are capable, and patients are also capable. We human beings are capable, in spite also we are suffering, but the suffering makes us actually powerful and strong. So the capable person can speak, communicate together with others, can act and be responsible for own actions. So we also integrated a capability approach by Sean Amartya. It's an Indian name. It's really hard to pronounce, but it's not a long name, as you can see my references here. He's a professor in philosophy and also in economics. But he and Martha Nussbaum, they worked with the capability approach. Everybody, if you are admitted to use your capabilities, you can make change. In his case, it was poor Indian women. So you have to ask yourself the question, what is this person able to do and what is she or he wants to do? So we formulated these simple routines to concrete, be some aid for us, help in our clinical work to perform person-centered care, to initiate the narratives, to listen carefully to patients about their daily life and also combine it with medical tests and examinations. We also developed this partnership by together formulating a health plan, and we safeguarded it by documented it in the electronic patient record. And together we can go and change and work with it. So the partnership is really the core concept in person-centered care. And as you've seen this slide, some of you before, we tested it in numerous trials. It's 25 around now, I think. And we see positive effects in every single trial, actually. So these simple routines based in ethic, they really make change. Thank you.
Thank you so much, Inger. And we will now turn over to Dr. Brendan McCormack, Professor and Dean at the Faculty of Medicine and Health at the University of Sydney in Australia. Okay. And you will present a model for person-centered practice. Warm welcome.
I will when the right one comes up.
Oh dear. That was... so that should be slide 3. Or file 3. According to...
I think it's...
4.
Oh, it's number 6 on that list, I think.
Yeah. Oh dear.
Yay!
It worked. Thank you so much, and you're welcome.
Thank you. Thank you, Joachim. Thank you, and it's great to be part of this panel. And I've got a very short time, and I'm going to not repeat some of the things you heard me talk about yesterday as well. But suffice to say that the work that I've been engaged in for 27 years has been with this framework, and this framework is now in its, I think, 5th iteration in terms of its refinement through the various studies that we've been doing over that period of time. I should say, though, that doesn't mean the framework has changed dramatically. All of the changes have been quite nuanced and quite small kind of refinements rather than significant domains changes themselves. Just a very quick background to this is that this work came from original work that I did in Oxford and that Tanya McCants was doing in Ulster. And when I moved to Belfast in 2000, we realized we'd actually been working in the same kind of area. And from that, and from lots of discussion and work, we designed the very first iteration of what became the person-centered practice framework. And since then, it's been used a lot. What I want to do is very quickly talk through what the framework tries to do. And I guess one of the core principles, and some of this might be, I hope is a bit controversial because I want us to have some controversy around all of this, is that we from the outside rejected the idea of just talking about person-centered care. And I know now I need to leave because it's a person-centered care conference. But because we felt the person-centered care, and there, from a nursing perspective, was problematic in the sense that people see it as this closed, kind of close one-to-one relationship or one family and person relationship, but that doesn't reflect the whole system of where all of these practices happen. And so we, from the outset, wanted to work with the idea of person-centered practice. And I think that issue of care versus practice has been problematic in this space, because very quickly, back when we published that first version in 2006, we were very quickly challenged by people like Mark Nolan in relation to relationship-centered care, saying, you know, this is too narrow to talk about person-centered care. It's all about relationships, and relationships are everywhere. And it kind of set off a whole journey of other people putting challenging frameworks to get past person-centered care. It's what I also think happened with the WHO and why they went for people-centered care, because it's a misunderstanding of what the word person means. And so we are in that complex space now, I think. But we stuck with person-centered practice, seeing that practice is everything. It's not just about that care component of delivery, it's all persons, which we've been hearing a lot about at this conference. And over that time, this framework has been adapted, has been translated into 14 different languages. We know from the work we've been doing trying to map where it is having impact, used in around 31 different countries. And a lot of work has been happening in relation to its implementation and development, including the development of an array of instruments to try and develop a package of tools to measure its use. But as I talked yesterday, it is very much a whole systems approach, and that is what we have been trying to do from the outset, to say, yes, person-centered care is important in relation to the actual experience that patients have, but it's also important to everyone who's in that space. All persons are equal. Personhood is not a hierarchy. There's no hierarchy in philosophy of personhood. Every person's personhood matters. And hence why we always have been really strongly focused on the personhood of healthcare workers and others as much as the experience of patients. The framework works from the outside in, essentially, recognizing that we all live and operate within this macro context that influences every day. Even if we're not necessarily conscious of its influence, it is influencing us all the time. It's kind of the frame that shapes what we do. So we have these kind of areas that are represented through these kind of examples of policy and strategy and influence that shape the way we practice on a day-to-day basis. But that policy is only as good as the people who are trying to make sense of it, and hence the domain of the prerequisites is about the qualities and attributes of the practitioner, be that a nurse, a doctor, a physio, whoever. What are the qualities and attributes of a practitioner that are needed in order to work in a person-centered way? And we identified these 5 core attributes, and we've heard a lot about knowing self and the different dimensions of self and what that actually means in different cultures and contexts, etc. And right through to the last one, there's probably the most controversial one in this that we've come up against, is this idea of commitment to the job. Because what that people interpret that as meaning you have to work harder and longer and all that stuff. And actually it doesn't. It's actually a phenomenological idea of being present, that when I'm doing my work, I'm really present in my work. I'm committed and I'm passionate about it and I'm there. But we use it as a way of getting people to think about that, about what does commitment really mean when we're talking about this kind of work. And again, there are all these kind of examples that help us to make sense of that. But I can have all the best qualities, attributes, and skills as a person-centered practitioner, but frankly work in a really crap environment. And I can't do it because the system stops me from actually putting them into practice. And we know that this is an issue from nursing burnout, from practitioner burnout, from all of the stuff that is going on in that space at the moment. And so the care environment we see as almost like the mediator to how the system operates and what actually happens in relation to staff and patient experience. And we've identified these qualities of the care environment or the context. There is multiple evidence to demonstrate the impact of context on patient care, on patient safety, on effectiveness, on implementation, on evidence uptake. So that's nothing new. But what is interesting about this domain is that these characteristics of the context have stayed stable really throughout this work. They have not really changed at all in the various places and the various domains and countries that we have worked with. And again, some examples of what that looks like in practice are those things here. So if we work on the environment, then we start to get into the actual provision of care, which we describe as the person-centered processes. And the person-centered processes are few, as you can see here. They are only 5 processes that we have tested time and time again as being essential to providing person-centered care. What is really interesting about these is that it doesn't matter what the setting is, what the specialty is, where it is that I'm practicing, or who it is that is practicing. These 5 attributes are the core that we identify as necessary to work in a person-centered way. The one that, again, in this domain that's most controversial, I guess, is being sympathetically present, because you will see empathy isn't mentioned here at all. Now, it's not that we reject the term empathy, because otherwise we'd be promoting psychopaths. But actually, what we are suggesting is that empathy doesn't go far enough, and actually is flawed when it comes to being person-centered, because I can never be you and you can never be me. I can never understand you and you can never understand me if I'm genuine about personhood. But what I can do is be alongside. I can again be in that phenomenological space of be alongside with you, work with you to understand, work with you to help, but not try and be in that space. It's impossible from a person-centered perspective. And there is increasing literature coming with that, because it's quite challenging to think about that. Again, some examples that we've seen happen to try and create these person-centered processes. And then lastly, if we're doing all of that, we end up with what we see as the core outcome, which is a healthful culture, a culture that is energy-giving, is helping everyone to flourish, both staff and patients and families and communities, and is a place that people want to be in. I have a paper came out yesterday around the whole challenge of the nursing workforce, which I've subtitled, do we have a shortage of nurses, or do we have a global shortage of places where nurses want to work? And I think it's the latter, frankly. And so we really kind of need to address this as a whole system. And for me, we cannot ask practitioners to provide person-centered care if we're not addressing all of these elements of the whole system on a continuous basis, and hence why it needs to be a continuous project. Thank you.
Thank you so much. And now we turn to Dr. Maria Santana, professor at University of Calgary in Canada, in the Departments of Pediatrics, Community Health Sciences, and the Cummings School of Medicine. You are specialized in public health and clinical epidemiology. And you will present a framework for person-centered care. Warm welcome.
Thank you so much for the introduction. Yeah, and thank you all of you for being here. It's a pleasure to share the chairs with a lot of dear colleagues and mentors, actually big fan of Brandon. So you might see similarities in what I'm going to talk about it, because it was very influential when the Healthcare Authority, I have to give you a little bit of background. Like, I'm in Calgary, in Alberta, and it's the Canadian province, the only Canadian province that for many, many years had a unified healthcare system. So the healthcare system is just one. Alberta Health Services is not fractionated like in other parts, in other provinces of our country. And so we had a visionary CEO, and that was a pediatrician, professor in pediatrics, and she said, like, really, I think that we need to make the system more person-centered, and how do we start doing that? And we were queuing outside bathroom because we were attending the same conference, and she said, Maria, I need to talk to you about person-centered care. Can you help me with that? And I said, well, yeah, let's do it. So we started to figure out how do we start doing this? How do we understand what person-centered care is? I mean, I saw different terminology, right? Also, Brendan just referred to that, and so we said, okay, academically, let's start looking at the evidence in the literature. I mean, like, what frameworks are there available? What are people talking about that? How can we learn from it? And then let's go to the health policy documents that we have in our province and across Canada, and see how they're doing it, if they're ever doing it. And then we extended into an environmental scan, and we validated the initial drafted framework that I'm going to show you with different communities in our society, like trying to be inclusive, so with different immigrants and refugees communities, and so on and so forth. let me start now with the presentation. The idea from the CEO was really to inform health quality improvement. How can we inform health quality improvement from the perspective of the patients? And this is because there is a huge gap that health quality improvement usually is being established by surveys that the clinicians developed or stakeholders that said, oh, we need, the clean hands policy or something. But the patients and the families, they were never included, and leave alone, the people that came through the doors. So how do we start doing that partnership? So going back to Dr. Eckermann, we cannot move alone if we don't have a meaningful partnership. So we started co-designing, co-developing, working together. And so we go to the question of how can we translate PCC into healthcare quality improvement? And this is the framework. I have to say, I'm not very artistic. So I developed the framework with my students and the team. And this is our colorful framework. So because it was focused on quality improvement, we said, okay, so now we identify all this vast literature about person-centered care, how to measure it, what is it, what are the frameworks. If we're going to use it for quality improvement, what is the framework that informs quality improvement? No-brainer, Don Obedian. And Don Obedian said, okay, this is very simple, don't complicate things. You have pieces that are structural related, the process, the care, and then the outcomes that you want to measure. What do you really, how do you measure all these three ones? And so we started putting everything that we found, merging it through that partnership, consultations, etc., into the three buckets. And there you have the buckets, and now I'm going to go into my bubbly presentation. So a structured domain. So what are the structured domains? So creating a person-centered care culture. Oh my goodness. We're still doing that. I don't think that we're close to that. We have developed indicators, we call it person-centered quality indicators, that have been integrated into primary care, into the medical home strategy for primary care. And we are measuring, the culture of person-centered care. Interesting. So there you have two main subdomains, so the core values, and I think Aneka was talking about the values, and thank you for sharing that paper. Yeah, really relating to this and establishing the definitions. Again, the terminology, what are we talking about here? And then how can we really standardize training? We do need to co-develop and implement educational programs. So more and more what we have seen is mostly in tertiary care, I have to say that is where most of everything is concentrated in healthcare. But yeah, some community clinics very successfully is the training for PCC. In fact, some of the community clinics and some of the tertiary care, specifically the teaching hospitals, when they're recruiting new people, they assess the person-centered care knowledge, what it means to them, what kind of values they have related to that. And that has been quite successful. Another structure that was super important, and is all related to a strong partnership and sustaining the partnership, which is a challenge, was co-designing and the development and implementation of health promotion and prevention. And I think you mentioned that. It's super important. And a real challenge when you don't have a homogeneous population, when the population is very diverse, and how they understand person-centered care, what is prevention and health promotion for them, and how can we support it. A big challenge at the moment with all the raising prices in food and resources available and so on. Supporting the workforce. So we recruited people that have values of PCC, but are we supporting them? What kind of support do we have? And what kind of budget do we have to allocate? So the ministry said, if you guys are doing this, how much is going to cost us? Didn't know. Just don't know. You have to calculate that. But and so then another structure that is important is how do you provide the environment? I think, Brandon, related to the environment is so important, and more In our neck of the woods, we have been building hospitals. The new cancer center has been co-designed with the architect, engineers, and patients and families. And so that happened with the Children's Hospital, where my office is. It's really lovely. And one thing is that, for example, when they come to clean the window cleaners are Batman and Spearman, and and the kids are like, yeah, come back to clean the windows. So, but I mean, like, no, you're kidding, but super important, the environment, having rooms where you can have a kind of more, private conversations, well, and yeah. Another one was information technology, and this is really a key preference at the moment with the movement on precision health. And so we have EPIC as an electronic medical system that really allows for integration and so on. And now the patients have access to a portal, and through the electronic portal, they can not only see their own data, but also they can communicate, send emails to their healthcare providers, which it really talks a lot about integration of care, facilitating coordination, but also the collection of data and different pieces of data. Like, for example, patient-reported outcome measures and social determinants of health. Creating structures to monitor PCC performance, and I think that yesterday I attended a session where it was a lot about how to do this and the importance of doing it, and not only for monitoring purposes, but evaluating the quality of healthcare. Now we are in the green bucket, that is the process of care, and an alignment with Brendan where he talked. So how do you cultivate communication? Another big, the provider said to us, we listen to the patients. We have only maybe 5 minutes, but we do listen to them. And of course, we share information, we give them a lot of information. And so what happened with the person, English is not the first language, or the culture, they have a different culture. How do we communicate with them? Do we really listen? Or, how is that communication, the sharing, the discussion of the care planning with the patients and the co-building the care planning? You do need to engage the patients. And for all of that, and you hope that by doing that during the encounter, they will continue to do that when they're outside. So now the electronic medical record has facilitated that kind of engagement. Integration of care, again, communication and integrating. So now it's really interesting what is been happening in the last few years since the precision medicine portfolio came to the Camion School of Medicine and the healthcare system is so working cross-sectorially, so integration of care. So not only tertiary care, but primary care, medical home cares, community centers, specific mental health community centers as well. And the outcomes was like really? Okay, so the outcomes were really assessed for quality improvement in terms of two of the outcomes that we're interested in, and we'll modify this a little bit, but this is the first one that we drafted, is access to care. So we know that the outcome, when we have access to care as an outcome, what we're looking is, are we providing timely care? And how that looks like, and then all the cost benefits of doing so, right? Less health services utilization, better healthcare. It was interesting when we started validating these domains with the communities, because when we talk about access to care, it was a priority for them. And some communities within our province, that is over 4 million people, they say, the problem is that I work till late and the clinics are closed. So, and people, workers, and more so like new Canadians working in construction say, well, I chopped my finger, my thumb off, and I didn't know I have to pay for the ambulance $500. So the financial burden also for dental care and other costs, and is changing. So the financial burden would be even worse. And then another outcomes that were interesting for them was the patient-reported outcomes. And among the 3 patient-reported outcome measures, the PROMs, the patient-reported experience measures, and the adverse outcomes. And that to me is not a brainer. I'm very fond of PROMs and PREMs as well, but you know how they see it was like if we regularly collect this information, we're not going to have only health-related quality of life information. All the bit of pieces of data that Axel was referring to is not only about blood pressure or hemoglobin levels. Now we have other pieces of the data that are related to people functionality, psychological outcomes, schooling, social life, you know, is expanding outside the walls of the clinical care. The same with the PREMs. Now we understand the experiences of the patients, and the reported adverse outcomes is no brainer, right? So, yeah. So that's it. That's the framework. Thank you very much for listening.
Thank you so much. And now, I want to introduce Dr. Victoria Stein, your assistant professor at the Department of Public Health and Primary Care at Leiden University Medical Center in the Netherlands. And you will talk about and present frameworks on integrated person-centered care.
Genau.
Warm welcome.
Thank you. Welcome again. I could just make it very brief and easy for the panelists and say same but different. There are hundreds of frameworks on integrated care out there. I will just focus on a few and really also focus on the perspective and how to maybe use them, what the strengths are, and also how you to implement them, because that's where my experience comes from. As I said, there are a lot of frameworks out there on integrated care. Some of them you may recognize. One of the oldest ones is the chronic care model from Wagner that was first published in 1998. Was never intended to be a framework, but is used widely across the world. Or also the Scirocco model, which is used across the European Union and is an assessment tool for systems to actually look at their maturity of integration. And obviously we have 2 WHO frameworks here. This one here is the one from WHO Global on the integrated people-centered system. But the one that I want to start with, and I have 3 because I've collaborated on all of them, is the European Framework for Action on Integrated Health Services Delivery. And that was developed, so I was coordinating 53 member states of WHO Europe. We also invited a group of experts, and we did extensive invitation and consultation with the different European umbrella organizations like European Patient Forum, Eurordis, etc. What I think is really interesting here is that it's obviously a policy framework. It was meant for ministries of health and national public health institutions primarily. So it really also talks about what do you need to change in the system, how do you need to incite also your organizations to change, and how do you involve communities, populations. But what I also think is really interesting here is that we, after several discussions and iterations, actually decided we need to have change management as a separate focal point and as a separate work package here, because it's so often overlooked. And we know it from the literature, we know it from experience, that usually when an initiative, whether it's integrated care, person-centered care, any change process, is just stuck on top of your everyday work, whether you're a manager, a professional, or a policymaker. Nobody actually acknowledges that change management is a task in itself and that you need dedicated people and time and resources to do it. So I think that is one of the strengths. When you visit the WHO Europe website, you have a toolkit there, you have a lot of case studies there. So there's also a repository of experiences of how to implement it and which kind of tools work in which environment. Secondly, Project Integrate, which was developed as part of an EU research project, the FP7 framework back then. And that actually looked at implementation more on the local and regional level. So how can we actually support managers who need to do the doing in implementing integrated care? Obviously, it was based on a literature review, and then we had 4 case sites. One of them actually was in Sweden, in Tiohundra, which is north of Stockholm. And it was based also on the idea that integration needs to happen on all of the system levels. So from person-centered care through to system integration. But you also need normative integration, so that's the culture and the values, the education, and functional integration. That's where IT comes in, communication comes in, technology and data sharing comes in. And so that is based on another framework, which is the Rainbow Model for Integrated Care. What is also helpful here is that it's actually designed as an assessment tool to see where are we at which level, and then using it to really come together as the implementers on whichever level you are and discuss those assessments and see, do we actually have the same impression of where we are? Are there priorities that we need to look at? Because we really score very lowly on, for example, sharing information. And it's also a starting point. We first actually intended it to be more of a continuous evaluation method, but actually we found out together with the case sites that this is really more of an implementation and continuous learning tool to support those discussions and support decision making on the different levels. It also really showed that you cannot go through all of those 7 levels of the system with everyone. Because it's sometimes very abstract for people working on the ground to talk about policy making. On the other hand, when we talk more to the system level implementers, some of the elements around functional normative integration with bringing together teams was something that they really thought wasn't relevant to them. So it was really interesting to see that you need to really think about the audience you're working with. And then finally, this is work in progress. This is the Population Health Management Maturity Index, which was developed by one of our PhD students over the last 3 years in the Netherlands. And it has been validated with an international panel. It's also been implemented in New South Wales in one of the local health districts and tested there whether it's actually transferable away from the Dutch context. And we're now discussing also with Canada and with the Dutch Ministry of Health to actually really use it as an implementation tool for their various reforms on integrated person-centered care. What is interesting here is that you actually also have an acknowledgement. Again, you need to work going back and forth. There are some key elements, key domains you need to address. But then at the same time, you need to start implementing. You need to actually start doing testing, learning, and then going back to the outer circle basically and thinking, okay, is this now ready for now? Can we move to another topic? Are there new priorities coming out? So again, it's a tool that helps you assess maturity, but also making decisions and really focusing, because one of the challenges that we've heard about is implementation is complex, and integrated care, person-centered care is complex. So breaking down complexity by really prioritizing what is it that we need to do now, as opposed to in 1 or 2 years, really helps the process. And so this, as I said, it's just been published, and we are working on implementing it and testing it in different countries and in different contexts. And it's, exciting to see. And so with that, in summary, as I said, there are many frameworks to choose from. Don't develop your own. Take one, adapt it, and that's fine. But really choose the one that fits your context and your setting and your audience, because that's really important. And there is no one right framework. Secondly, they all recognize that you need to intervene on different levels of the system. So really think very clearly about who is your audience, what's your perspective, and what do you need to focus on. And then, for example, if you really want to challenge the system level, using WHO frameworks is usually a lot easier. If you really want to work more with the management or the professional level, then there's other frameworks which are probably more useful for you. All of them emphasize community involvement and co-design and stakeholder involvement from the very beginning. So from the day you actually want to do something, change something, really involve people and ask them, what is it that we want to do together? Where are the challenges? If you don't do it, and I can tell you because I've been supporting implementation for a long time now, it will come back to haunt you, because every project that so far that has developed a beautiful framework in a team somewhere and then gone out and implemented it really failed, because people just said, well, why should I do that? You never recognized me. You didn't really do that. You didn't ask that question. Why didn't you ask us? So really co-designing is an essential tool in the implementation. It doesn't matter what. And then finally, any framework is a guide. It's a starting point to really come together and discuss where are we at, what do we need to do, what do we want to focus on. They're not tick box exercises. You really need to put in work, and you really need to think about what works, how can we measure it, how can we then improve it, how do we feed it back. So a framework really also is a tool to create a learning environment and a learning organization. Thank you.
Thank you so much. So this is wonderful, having these kind of, at least an overview, brief overviews of 4 different framework perspectives. And to continue and facilitate a discussion for the coming sessions towards the state of the science in person-centered care, we invited David Edwardson, Dr. David Edwardson, to give us brief commentary as kind of paving the way for continuing the discussion. And David has a PhD from Umeå University in Sweden and is professor at La Trobe University in Australia. You're welcome.
Thank you, Joachim, and thank you, everyone. No pressure, you know, off the cusp, provide a commentary of these brilliant presentations. I think in short, thank you, Victoria, I agree with you. You gave all the recommendations, so I don't have to say anything. No, but really, I would like to firstly become a bit philosophical and then move to some reflections, if I may. And the first sort of reflection, philosophical reflection, is, you know, the power of the person. Sitting here with these brilliant persons, you know, and the power what people can achieve, you know, individually with passion, but also collectively sitting at this conference and seeing, you know, everything that is happening, the power of the person with a passion, with an interest, teaming up with others and making change. And I think we've seen that in various ways in the frameworks, and it comes back to that, and it's, you know, it never ceases to impress me. So thank you, everyone. It's fascinating, and for the conference and for this session. That's the philosophical part. We're moving, you know, it's an interesting field and it's an interesting time. We're moving between, and I made sort of a mind map between philosophy and prediction, between self-care and data analytics, between vulnerability and capability, between precision and partnership, practice and care, person and people, symptoms and genetics, change and integration, prompts and prams, and I could go on. And just listening to Axel's sort of very contemporary overview of, and I think you're absolutely right, Axel, in terms of precision medicine and medtech, and connecting the power of technology with the power of the person. That has changed the world throughout the beginning of time, and it will continue to change the world. And I'd like to come back to what Eric Sutherland said in the opening address around AI and digital health, and he used the analogy of electricity. I thought that was brilliant. How do we harness? And the impact of AI is likely to be as transformative as electricity was back in the day. How do we harness it? How do we make it safe? How do we make it useful? But how is it then being applied to support people's health, to support prosperity, etc.? And you touched very well on that, Axel, so thank you. And then Inger, all the work that you've done connecting philosophy with operationalization, and I think that's a real strength that also comes through most of these theoretical frameworks, recognizing the person, recognizing the ethics, the capabilities of the person, and then transforming that to models, the GCPCC framework that actually is then supported by a strong body of evidence. It's incredible. And Brendan, I mean, all the work that you've been doing, around and very methodically looking at, the different concepts of practice, culture, not trying to focus on one part, but actually have the integrated systems whole. It's very impressive. It's, the testament that people are using it all around the world all the time, and that you're still passionate. It's really amazing. That framework and how it's sort of visually different to the other ones, because it's sort of it's circular and holistic in that, whereas, Maria and then Victoria had more process and integration. So even visually, they're slightly different, and they touch upon different things. Maria, talking about quality, linking to co-design, collaborations. We have a lot of different concepts that overlap, but describe slightly different things, but also overlapping things. I think that's very useful. And also the representation from various countries and how similar things can be, but with a cultural twist. And that sort of encompasses most of the models as well, which is fascinating. And then obviously Victoria, that has all of this excellent overview of the different frameworks and the integrated care and the relationship to person-centered care, and how also the change management and bringing in sort of a slightly different business perspective on things, which is extremely useful. And when you spend time listening to Victoria, that the two things that scares us the most is change, but then staying the same. That's brilliant. So I think just a bit of a prediction then, relating back to Axel was talking about. I think in the conference, but also the direction of GCPCC in trying to have an ambitious aim to integrate and to provide an overview of the state of the science that is quite diverse, but with a shared common value or common philosophy. And then looking at that it's not profession specific, it's not disciplinary specific, it's dressed in different languages in different countries, but then we need to look at how do we harness the power of technology with the person in mind? How do we predict? How do we govern these sort of things? And ultimately, coming back to Erik as well in the opening address, that people will need to be supported in making their own decisions increasingly, and with AI and with medical technology and these frameworks, supporting the person in various ways at various levels, macro, micro, and meso, to make the best decisions supported by health professionals. So I would like to thank on behalf of the room, the panel members, and really looking forward to more discussions. But it's been a great overview. Thank you, everyone.
Yeah, so we hope the discussion will continue in the afternoon, and we could, yeah. So I think we are about to close the session, and you're invited to continue. And the next session will be presentations of reviews that will inform the current knowledge about person-centered care, and that will followed by group discussions. And both these two sessions will take place in J4. So maybe I'm confused, but I think it is over there.
It is.
And see you there after the break, and before that we have, of course, poster sessions and poster walks. A warm thank you.